Hello, my name's Tom McGarrian, and I'll be talking to you today about co-occurring disorders that occur in the context of autism. I am a clinical director at the Thompson Autism Center at CHOC. I also serve as the chief of the Neurodevelopmental Medicine Division at CHOC Children's Hospital. By way of disclosures, I serve as a consultant for Kuzani Pharmaceuticals. I work with Yamo Pharmaceuticals as a chief medical officer, consulting for Cognoa, and have been a past reviewer for the FDA's Pediatric Medical Device Consortium. Objectives for this talk are, hopefully, if I do my job, you will have a better understanding of the unmet needs of children and adolescents and young adults with autism under current care models for taking care of co-occurring problems and disorders, helping to identify the benefits to collaborative models of care for this population, and helping to understand the successes and challenges of delivering care under this model. I'll start off with a case study. This case pertains to a young man named Joseph, who's 14 years old. He was previously diagnosed with autism spectrum disorder level 1, and he presented to the clinic with symptoms of inattention and hyperactivity, as well as obesity, depression, some hypomania associated with the depression. Also has a history of epilepsy that's been treated with levetiracetam. He had also begun having headaches about 6 months prior to presentation, and these headaches were associated with photophobia, which means light sensitivity to light. He also had nausea and vomiting that was associated with the headaches. In addition to the vomiting, he has a history of intermittent diarrhea and abdominal pain. He does like to drink chocolate milk a lot and eats cheese pizza for lunch every day. He does have an individualized education plan in place and is in a mainstream classroom, but receives pull-out services. He's been recently expressing sadness over not having friends, and his mom is not sure that his IEP is sufficiently addressing his needs. He has a co-occurring appointment with psychology, psychiatry, neurology, and gastroenterology. So what this case, I think, highlights is the problem that we see in caring for kids with autism, which is that they don't need just help for the autistic specific symptoms, but they really also need a holistic model of combinational or multidisciplinary care. Because, believe it or not, 95% of kids with autism have about 5 other disorders associated with their diagnosis. These range from disorders such as anxiety, ADHD, sleep disorders, to more medical disorders such as seizure disorders, gastrointestinal disorders, and allergies. So what I'd like to really get across to you is that autism spectrum disorder is really not a single disorder. Although we call it a disorder, it's really a common syndrome. And as Geschwin and State have noted in a recent article, it is a disorder that's combined or comprises, at least in part, several hundred rare disorders. The analogy I like to give is that autism is very much like the way we thought of cancer or anemia or dementia before we really understood that each of these disorders has multiple causes to the presentation. So in the case of anemia, where a person has low red cell counts, they can have that because they have a bleeding disorder. They can have it because they have sickle cell anemia. They can have it because they have another inherited anemic disorder, or they can have it because of a drug that they're taking, or an autoimmune disorder. So there are many different causes, and if we try to treat that disorder, anemia, with one intervention, say iron, that would only work in a fraction of the time, and most of the other times it wouldn't work. So we really have to start looking at autism the same way, that it is a description of symptoms that result from that are the result of a multitude of different disorders. And that's really key when it comes to understanding co-occurring disorders in the context of autism. We'll get to that in a minute. So there have been more than 100 genes that have been implicated as risk factors or causation for autism. Examples include the SHANK3 gene mutations, which are responsible for the syndrome of Phelan-McDermott syndrome, the fMRI expansion, which is responsible for Fragile X syndrome, duplication of the 21st chromosome so that there are 3 copies, which is responsible for Down syndrome, mutations in the MECP2 gene, which is responsible for Rett syndrome, mutations in other genes such as the neuroligin 3 gene, and there's a whole host of them. And each one of these can present as autism. What's important to realize is that the autism-related genes also are involved and raise the risk for non-autism disorders. We do know now that many of the same genes involved in autism, either risk or causality, also cause other issues, especially in the neuropsychiatric domain, but also in the neurodevelopmental domain and the medical domains. And that's because of the shared genetic underpinnings that is common across these different disorders. There was a really very interesting and educational study that was done in Sweden around 2015, studying twins and the rates of autism between those twins, as well as co-occurring diagnoses. So in 272 patients that the investigator looked at, he found that only 4% of the children had pure autism and no other disorders. In fact, 50% had 4 or more disorders in conjunction with their autism. And because of this, one can easily make the case that there has got to be a common genetic component for many of these disorders. Why else would twins who are identical have such a high rate of agreement with these disorders that are occurring in conjunction with autism? The overall prevalence of psychiatric and behavioral disorders that these children exhibit and that we see in general in children with autism is definitely much higher than it is in the general population in children without autism, which we will review shortly. Other studies showed that monozygotic twins who are discordant, meaning that they don't have autism between the two SIBs, even though they're identical, and that happens about 10% of the time, those individuals still shared other cognitive coordination or developmental delays, or even things such as attention deficit disorder hyperactivity. In other words, even though they both did not have autism when you would think they would, they still had another developmental disability, which again speaks to that overlap between genes and disorders and causes of autism that also may in fact cause other disorders. And when you look conversely at dizygotic twins, only about 10% shared some type of developmental disability. So those twins where they did not share, they were not identical, did not share autism, but one had a developmental disability, the chance that the other sibling had developmental disability was only about 10%. Again, speaking to that genetic link. So what are the common co-occurring disorders that were seen in these identical twin studies? Well, the number one, the most common, was ADHD. About 80% of the SIB cohorts, the twins, had ADHD present in both pairs. Learning disability was 75%, tic disorder was 36%, so was oppositional defiant disorder. Obsessive compulsive disorder was about a quarter of the children, SIB pairs, and then a composite consisting of developmental coordination disorder, executive dysfunction, and visual spatial difficulties was seen in about 3/4 of the kids, indicating really a high prevalence of these disorders seen in pairs, in both SIB pairs, in identical twins. So when we look at the way that co-occurring disorders occur in the context of autism, and we see that in the case of ADHD or one of the other disorders we mentioned, that there is a high concordance rate, meaning a high probability that if one identical sibling has autism and has ADHD, the other one will, or tic disorder. And in this case, in the example here, 44% agreement between SIBs that have autism and ADHD. The really interesting thing to think about here is that it's not 100%, right? So when we look at children with autism who are a pair of identical twins, the rate of co-occurring autism in the sibling, it's about 90%, but it's not 100%. But the rate of co-occurring agreement between siblings that have autism plus ADHD or tic disorder and their sibling having the same presentation, in other words, ASD plus the same other disorder, it's even lower than 90%. In this case of ADHD, it's 44%, compared with 15% if it's a twin that is a fraternal twin. And so what that tells you is that it's not all genetics, is it? It's also the uterine environment. It's the epigenetics as well. It's the other things that can happen during either in utero development or early postnatal development that cause activation or inactivation of certain genes that lead to the expression or the presentation of these other co-occurring symptoms. That's why the rates of autism plus one of the other disorders differs even between identical twins compared to a fraternal twin, because we know from this that there are many genetic and environmental factors that have to be in common across autism and ADHD, learning disabilities, tic disorders, other developmental disabilities. So it's not a one-to-one correlation, and it really does show you the role that the genetics plays in conjunction with the environment. In reviews that were done in 2016 and 2020, I put together a summary of the point prevalence. In other words, at any given time, what's the rate of occurrence of other disorders in children with autism. So these tables that you're seeing here are all refer to children and adolescents that have a diagnosis of autism. And the point prevalence estimate that a child with autism also has a diagnosis of attention deficit hyperactivity disorder is about 30%, with a range of about 30 to 80%. So anywhere between 30 to 80% of kids, depending on the study, who had autism also had a diagnosis of attention deficit disorder. Contrast that with the prevalence in the general population of children who don't have autism, which is only about 5%. So you can see that there's a 6 to 7-fold increase in rates of ADHD in children with autism compared to the general population. The other way to look at this is how many children with ADHD have autism. That's also has a high concordance. Between 20 to 50% of kids with ADHD may also have a diagnosis of autism. Depression also occurs at a higher rate in children with autism, as do other bipolar and mood disorders. Depression about 11%, bipolar mood disorders, bipolar and general mood disorders overall 18.8%, bipolar about 5%, and the range you can see is quite wide, going anywhere from 4.4 to 37%. In kids with depression and autism, you should compare that to the general population of atypically developing children, where depression has rates of about 3.5% in adolescents. These numbers are actually likely higher now than they were when these studies were done. As we do know, there's a mental health crisis in this country, and depression rates have really kind of skyrocketed. Even in typically developing kids, numbers are upwards of 11%, but that also means that the numbers for kids with autism have also increased. It should be noted that self-injurious behaviors, that's what SIBs are significantly correlated with depression. So children with autism and depression do tend to have more self-injurious behaviors, especially in higher functioning children. Anxiety is another very common co-occurring disorder in children with autism. About 40% of children overall, 35% of adolescents report having an anxiety disorder in conjunction with their autism disorder, and the rates, just like with autism, go up to 80% depending on the study. Social anxiety is the most common or prevalent type of co-occurring anxiety disorder. And anxiety disorders definitely seem to be associated with higher IQ and lower severity of autism spectrum disorders. Other disorders that we see in the neuropsychiatric and behavioral domains, sleep disorders are extremely high. Anywhere between 50 to 80% of children with autism have reported a sleep disorder versus 9 to 25 in the general population. The type of sleep disorders that children with autism report having are latency latency issues, which means they have take longer to fall asleep, so on average about 11 minutes longer. They sleep less. Their total sleep time is on average about 30% less. Their sleep efficiency is about 2% less. And then, of course, sleep disorders can be confounded by other disorders. Obsessive compulsive disorder, which normally has a prevalence in the general population of about 0.25% at any given time, with a range of about 1 to 3% in children and adults over their lifetime, has an almost 18% prevalence rate in children with autism, with a range of 2 to 37%. Looking at disruptive impulse control conduct disorders, oppositional defiant disorders, in the general population, that's usually between 1.5% to 3% at any given time. But at any given time, a point prevalence in kids with autism is about 12%. The range over lifetime is about 9 to 11% for typically developing individuals, but that's basically looking at the entire lifespan range. Tic disorders are also very common, as are Tourette syndrome in children with autism. Again, in the general population, usually between 0.3 to about 10% of the general population has had a tic, either transient or a simple motor or simple vocal tics. But in the autism population, about 22%, roughly a fifth. And about 10% of kids with autism have a diagnosis of Tourette syndrome versus about 0.4 to 3% in the general population. Eating disorders also seem to be a little bit higher in the autism population. So 7.9% versus 0.3% for anorexia in the general population, but avoidant restrictive food intake disorder in the general population does overlap with the numbers we see for kids with autism. Intellectual disability is a very big co-occurring disorder in children with autism, almost 50% of kids. The ranges, though, are about 25 to 70%. And it's usually the usual quotations that people mention are about 20 to 30% of kids with autism will have true intellectual disability. It is, intellectual disability is usually associated with more severe symptoms of social, behavioral, and motor issues. Epilepsy also has a range between 5 and 40%. Commonly, about 12% at any one time of children with autism will have epilepsy, compared to about 2 to 3% in the general population. Risk of epilepsy goes up when you have the co-occurring diagnosis of intellectual disability. So if you have intellectual disability and autism, the prevalence is about 21% versus if you don't have intellectual disability. And there seems to be a higher risk in females with autism developing epilepsy compared to males. Cerebral palsy also has a higher risk. Almost about 5% of kids with autism have cerebral palsy, and about 50% of kids with cerebral palsy, conversely, have symptoms of autism. Children with autism and co-occurring cerebral palsy tend to have more repetitive and restrictive behaviors and other medical and developmental conditions than those without cerebral palsy. Migraine is also more prevalent in children with autism, although it is a harder entity to study because of the fact that in many cases it's hard for children with autism to communicate that they're having a migraine. So studies have really pegged a range between about 30% to 60% co-occurrence with autism. That's compared to about 7.7% in the general pediatric population. Gastrointestinal problems are a big problem that we see in children with autism. About a quarter of our kids will have will report gastrointestinal symptoms at any given time, and that range can be quite high, meaning that over the course of a child's life into adulthood, almost 90% might report at some point having gastrointestinal problems. Constipation makes up a big portion of that. Abdominal pain also is a big complaint that we see in children with autism, and it may correlate with the severity of autism symptoms. Constipation and diarrhea are the most common, but we also see gastroesophageal reflux as being a commonly co-occurring gastrointestinal symptom in autism. It's worth taking a little bit more look at gastrointestinal problems in autism because they are so prominent and prevalent. And a review that I pegged here or pulled out for you guys to see is kind of, first of all, this wide range depending on the report, but comparing autism to children who have other disorders. So the dark bars are the children that have autism. And you can see in this particular study here by Horvath, about 80% of kids with autism had abdominal symptoms or GI symptoms compared to 30% who had some other disorder, non-autistic disorder. And you can see that in every case, virtually every case, no matter what other disorder kids were being compared to, their prevalence of GI symptoms in autism was much greater than if they had some other non-autistic disorder. Both functional and organic conditions are elevated in GI problems in children with autism. So we have chronic constipation, chronic diarrhea, abdominal pain, as I mentioned, GE reflux. And GI disorders do worsen behaviors. We do see children having more episodes of irritability, agitation, aggression. Sometimes it's just sobbing and screaming, and especially in the non-communicative child, very difficult to figure out what's going on. So when a child is irritable or engaging in sobbing or screaming, we do like to look for potential problems with coming from the GI tract, and sometimes we will treat even expectantly, even if we don't have a firm diagnosis. We might give a trial of a proton pump inhibitor to see if reflux might be at play and causing the irritability of the child. The other thing to realize is that GI problems also disrupt sleep. And because of that, there's a really interesting interplay between GI problems, anxiety, and other behaviors. So it makes sense that a child with more GI symptoms, especially if they're nonverbal, will have more anxiety, and more anxiety will also elicit more GI symptoms. So you get into this vicious cycle where you start off with GI symptoms, and that may cause increased anxiety in the child, which may in turn lead to poor sleep, which may in turn lead to more irritability, which may in turn feed those GI symptoms. So we can get into this really difficult to break loop. Other medical diagnoses in autism that are less prevalent and less well known, but do occur in a higher frequency, especially in certain subgroups of children with autism, include urticaria, 8.5% in kids with autism versus about 6% in kids who don't have autism. Urticaria may correlate with the severity of symptoms of autism and may also be associated with constipation and diarrhea. Asthma and allergic disorders. Asthma has almost a 20% prevalence in kids with autism. And there's about a 60-70% increased likelihood of asthma in a child with autism compared to the general population. Also a higher incidence of eczema or skin atopy in children with autism, 15%, and food allergies. When you look at some of the impairments, sensory impairments such as hearing and vision, it's interesting. About 1.5% of kids with hearing loss have a diagnosis of autism. Conversely, 9% of kids with hearing loss have a diagnosis of autism. That number goes up. The number of percentage of kids with autism with hearing loss goes up if you look at not just pure autism, but autism plus. So autism in the setting maybe of a syndrome, you'll get a higher incidence of hearing impairments. Vision impairments, some type of vision impairments is reported in up to a quarter of kids with autism. These can take the form of actual difficulty with visual acuity, or oculomotor alignment, such as seen with strabismus, where you've got a misalignment of the eyes. So how do we think about why autism has such a frequent occurrence with certain co-occurring disorders? And some authors, Ty et al., put together a model that I like from about 12 years ago. And I think it really drives home how this could be happening, why these disorders occur more frequently with autism. One is the common denominator model, I call it, where there's a genetic or an environmental risk, and that genetic or environmental risk has a mechanism. It might be abnormal neuronal development, it might be an abnormality of neurotransmitters or neurotransmitter receptors, and it leads to both autism and a co-occurring medical or psychiatric condition. In this case, it produces an individual who has autism with anxiety. In another model, called the parallel pathway model, where there are two independent pathways. In other words, a medical condition that is either caused by something that happens in utero, or it could be some genetic inheritance that leads to an occurrence of, let's say in this case, epilepsy, and then another genetic or environmental risk that makes the child have a risk for autism. And because they have both of these risks, the child ends up with a presentation that includes both autism and epilepsy. In this case, it might be that because the child had the genetic risk factor for epilepsy and may have also had an exposure in utero to, say, an infectious agent, the two in different paths of the two different causes made this child at risk for two different disorders. And then the last is a case where you have a single cause that produces, say, a medical condition, and then that medical condition also produces the autistic phenotype. And an example of that might be cerebral palsy, so an in utero brain injury. And that in utero brain injury, which is going to lead to spasticity and or movement disorder that is characterized by cerebral palsy, also causes damage to an area of the brain that also puts the child at risk for developing autism. It's also, I think, real interesting to see how our recognition of co-occurring disorders has changed over the last really couple of dozen years. But in looking at this particular study, which looked at the change over 8 years, we saw an increase in about recognition by about 15%. So 15% more children were recognized as having co-occurring disorders between 2002 and 2010. They didn't actually increase the amount of co-occurring disorders. That didn't change, but what did change was our ability to recognize and think about the fact that children with autism do have other disorders. What also has changed is the Diagnostic and Statistical Manual. Previously, before the current DSM-5 edition, really made it difficult to diagnose a child with autism with co-occurring, say, ADHD or anxiety, and would really prevent us from making those co-occurring diagnoses because it was often assumed that the attentional issues were a result of the autism, or the anxiety was a result of the autism, or the mood problems were a result of the autism. And now we've been enlightened and we realize that children with autism, just like everybody else, can have other diagnoses and do have other diagnoses. And in fact, they have them at higher rates because of the genetic underpinnings that share the causes between autism and those other neuropsychiatric disorders. So we were pretty ignorant, about 20, even as few as 20 years ago, in thinking about our kids with autism having other diagnoses. In Orange County alone, we did an analysis and looked at what are the diagnoses that our kids with autism are seeing. So in general, in Orange County, we see about 500 new cases of autism per year. There's about 11,000 kids under the age of 18. with a diagnosis of autism. 86% of that number is under the ages of 12. And these patients typically have comorbidities and will require services from pediatric medicine. You see about a third of kids are going to see their pediatrician for a co-occurring disorder that might be GI problems, might be sleep problems. About a fifth are seeing neurology. Another fifth are seeing psychiatry or behavioral health. And then about a quarter are seeing other specialists. And the top diagnoses that we're seeing in Orange County are just like what I've mentioned before: attention deficit disorder, other developmental disorders of speech and language, so speech delays, learning disabilities, urinary incontinence, epilepsy, genetic disorders, and then GI disorders such as constipation. And how are we approaching this now today? And at the Autism Center, Thompson Autism Center, we really kind of set the system up to provide a home for kids with autism and neurodevelopmental disorders in general, who had other co-occurring disorders, so that they could see those individuals, they could see specialists for those individual disorders in one place, and didn't have to go for 5 or 6 different appointments to 3 or 4 different providers. So we were targeting the children who had we were targeting the co-occurring disorders that were high occurring frequency: ADHD, OCD, so some of the psychiatric disorders, as well as the medical disorders such as seizures, GI disorders, and sleep disorders. We also are targeting the typical disorders, if you will, or the typical care that many of our kids with autism need, but have difficulty getting because of their underlying diagnosis. So that includes routine eye care, routine dental care, and even eventually ear, nose, and throat care. And our current service lines at the Autism Center include, for co-occurring care, include psychiatry, psychology, developmental and behavioral pediatrics, neurodevelopmental neurology, and those are geared or aimed toward treating ADHD, depression, mood disorders, disruptive disorders, oppositional defiant disorder, anxiety, OCD, agitation, and aggression. We also are treating GI disorders with our GI specialists, and those range from constipation to abdominal pain to chronic diarrhea. We're also seeing kids with migraines, tics, epilepsy, sleep, and now neurometabolic disorders that have co-occurring neurobehavioral disorders, and starting soon some dental services as well. So the model of care for co-occurring services that we have implemented at the center puts the patient and family at the center of providing expedited communication, efficient care, and coordinated care. On the aspect of expedited communication, we focus on making sure that clinical specialists have time to meet with the family and the patient, and then work together to align on a care plan. That's the coordinated care aspect. And that coordination comes between specialists, family, social work, resource specialists, and with the output of having an efficient care model where a patient and family access everyone they need to: specialists, the social work, resource providers, our families, agencies, and schools together provider, all at that same visit. This decreases the burden on the family, prevents children from missing their therapies, missing school for multiple appointments on multiple different days, and also helps family not miss work. So let's go back to our case that we started the presentation off with. Joseph, if you remember, he's a 14-year-old male who has level 1 autism, and he presented with symptoms of inattention, hyperactivity, and obesity. He also had depression with some hypomanic symptoms, and he also has a history of epilepsy that's been successfully treated with levetiracetam. About 6 months prior to this appointment, he began having headaches that was associated with light sensitivity, called photophobia, and also nausea and vomiting. And in addition to the vomiting, remember, he had a history of intermittent diarrhea and abdominal pain, but also we know likes to drink chocolate milk frequently and eats cheese pizzas every day for lunch. He does have an IEP with pull-out services, but he's expressing more and more sadness about not having friends, and his mother questions whether his IEP is adequate So this appointment that was put together was scheduled with psychology, psychiatry, neurology, and gastroenterology specialists. At the time of the visit, the team meets with the family, does an examination, takes a detailed history, and then goes into the conference area, which is outside the patient room, to collaborate and come up with a treatment plan. And in this case, both gastroenterology, psychiatry, and neurology agree that levetiracetam might be contributing to some of the child's hyperactivity symptoms, and that valproic acid or Depakote might be a better choice because it will address seizure control, but it also may address some of those mood issues, especially the hypomania, and is also known to be a migraine prophylactic agent, prevents migraines. And the headaches appear to be migrainous in nature. Gastroenterology is also concerned that the history of abdominal pain and vomiting could also be a variant of migraine known as abdominal migraine. And so they're eager to see if treating the migraine symptoms with Depakote might help with some of the GI symptoms. Although GI is still concerned about the diarrhea, and both psychiatry and GI worry about putting this child on a stimulant to treat possible ADHD, which is what psychiatry is concerned about given the hyperactivity, as well as the fact that the child is struggling. And so thought is brought to giving or a trial of a stimulant. However, a gastroenterologist is concerned that a stimulant might worsen the diarrhea because it does increase gut motility. And so they agree on a non-stimulant medication, atomoxetine, which might help with the ADHD as well as some of the depressive symptoms. And if this child does have hypomania, a stimulant is probably not the best idea to give him. Gastroenterology asks for a stool sample and blood work that will be done to rule out celiac disease and recommends diet modification to see if excess dairy intake is contributing to the diarrhea, given the history of this child's love for dairy products, chocolate milk, and cheese pizzas. Psychology has decided to meet with the child weekly to work on the depressive symptoms, anxiety, and executive functioning skills, offering coaching, and offers to have a parent and child together join the peers group starting next month. Families, agencies, and schools together, specialists, meets with the family as well, reviews the IEP, and agrees to contact the school to see what other services might be available to address mom's concerns, especially around social issues. The nurse goes over the instructions on how to taper the levetiracetam and start Depakote, and then a follow-up with the entire team was scheduled for 12 weeks to evaluate the outcome of this intervention plan. Appointment is scheduled to see the nurse practitioner just for a medication check in 4 weeks to see if the atomoxetine and the Depakote doses are effective or need to be adjusted. So how is this model working for us? Well, between March of 2020 when we opened and February 2022, we had about over 2,500 visits that were telehealth because we opened in the middle of the pandemic. So we had to convert this model to a telehealth model, and we saw a large number of kids. In person, we started to see kids later in 2021, early 2022, so we started to see some more in-person visits for the co-occurring care. And you can see here how we have transitioned over time from the dark blue lines and light blue lines here, which were our total number of visits, but also our telehealth visits. And you can see that the telehealth visits contributed a very large percentage to our overall care, and that's changed obviously over the last year. This note down here, these years are fiscal years, and our fiscal year runs up through June. That's why it says July to February here for 2022. And here's a breakdown of the most common disorders we're seeing for our co-occurring clinic. We're seeing, as you can see, the most frequent are sleep, followed by speech delays, attention deficit disorders, behavioral disorders, anxiety disorders, mood disorders, and constipation, and then epilepsies down here at about number 8. Another case to kind of give you a sense of how this works is Tamara, who's a 5-year-old female with autism who presents with feeding difficulties. She also has fine motor delay, constipation, poor weight gain, and irritability, and engages in self-injury, oppositionality, and prolonged sleep latency. It takes her a long time to fall asleep. Her family's been using diphenhydramine, Benadryl, to help her with sleep, and she does have ABA in place. She comes to the clinic and sees a gastroenterology specialist, a neurodevelopmental specialist, a sleep specialist, psychology, all in our co-occurring clinic. The team meets with her and then confers and decides on the following treatment plan. The neurodevelopmental neurologist decides to start a trial of risperidone for the irritability, for the self-injurious behaviors and the oppositional behaviors, which will also address the gastroenterology concern over poor weight gain because the child's not eating well, and obviates the need or prevents us from needing to start another appetite stimulant, which normally gastroenterology might consider to use cyproheptadine, but instead of having 2 medications be put into place for this child, we're able to, because both providers are there, they're able to agree on trying one medication, namely risperidone, which is also an appetite stimulant. The GI doctor also decides to start Miralax and recommends supplemental Pediasure to help with weight gain, and also makes a referral to occupational therapy to work on both feeding and fine motor issues. Sleep specialist advises a trial of melatonin at night to help with the sleep onset, and psychology has decided to work on sleep hygiene as well through parent training and on how to handle the child's irritability, oppositional behaviors, and self-injurious behaviors, giving the parent some recommendations for interventions they can use at home. A follow-up is planned with the team in 8 weeks to evaluate the outcome of the intervention plan. So you can see that we've had pretty good satisfaction with this model. These are our satisfaction scores. The percentages means that the parent is asked to rate their satisfaction of their visit on a scale of 1 to 10. Credit is only given if they score a 9 or a 10. So this is really a binary. If the parent scores a 9 or a 10, that's considered, yes, they're satisfied. If they score an 8 or below, they're not satisfied, even though an 8 is still pretty good. And so the percentage of parents scoring a 9 or a 10, you can see here, is really kind of been very, very high. We've had kind of one period, couple of periods where we dropped below 90, but for the most part, we've done pretty well. Some of the comments we're getting, being grateful that their child's been able to see multiple specialists, to see the psychologist as well as the doctor. This parent mentions that they love their team. Again, that big emphasis here being on the multidisciplinary team and the families recognizing that they're seeing a team. Parent was very nervous about their appointment, but pleased with the staff's reassurance and explanations, and then really good, great support from our nursing staff. So that's what we tried to put together. And fortunately, I'm not here to answer questions, but if you do have questions, please feel free to email me through contact information that Chelsea can share with you. Thanks for your time.